Good morning, everybody. It is my pleasure to welcome you to this special Siemens Healthineers ESOC TV live slot. My name is Hanno Hermann. I'm with Siemens Healthineers. In there, I'm taking care of business development in interventional radiology, which also includes neurointerventional procedures. And also, I have the pleasure of looking into our strategy, how to prevent strokes. Today with me, I have two guests. On the one hand, we have Professor Jan Liemann from the Klinikum Nürnberg. He is the head of neurology. And with him, we have Dr. Markus Holtmannspetter, who is the head of diagnostic and interventional neuroradiology. Welcome. I'm glad to have you here.
Thanks for having us here.
Thanks for the invitation.
It's our pleasure. So today's talk is a little bit about, as I've said, Siemens Healthineers. I'm taking care of our strategy for stroke prevention. Also, we are looking into how to improve the pathways of acute stroke patients. And for us, it is very important to understand really what the challenges for you as clinicians are. Also, a little bit learning about what causes strokes and what can be done to detect strokes earlier, or the risk of a stroke which can occur, and also potentially how to avoid a second stroke from occurring. And for that, I've noted a couple of questions, and I would be glad to discuss those with you. Professor Liemann, stroke, as we know, is a disease which is actually caused by a multitude of underlying diseases. Could you please quickly elaborate which are the most common stroke etiologies? And is there also a share of strokes which actually have no clear origin? So do they have some sort of an unknown source? And is there any considerations currently in the clinical research where there is ways how this number specifically of these unknown strokes can potentially be lowered?
Yes, thanks for this question. It's very important. We have, if we focus on the LVOs, so the large vessel occlusion strokes, they are mostly from either cardioembolic or atrioembolic origin. And although we know that most of these strokes are originating from there, still some papers say up to 40% of stroke etiologies are still unknown, even after complete workup. So that's a really important number, 30% unknown source, and we don't know what actually we can do for the patient. Is a hard number we have to focus on next years. There's actually some focusing ongoing on this topic. One thing is prolonged Holter monitoring or implantable monitoring devices for heart rhythm detection, as we know that atrial fibrillation is the main cause of cardioembolic stroke. There's currently some research going on, focusing on that. But also some other focus has to be on imaging on the heart, in my opinion, because atrial fibrillation is just one symptom of a heart disease, and what we need to find is the plaque or the embolus within the heart. And what we normally do is we do this ultrasound within the course of the disease. The patient enters the hospital, gets this acute treatment, and then enters the stroke unit, and then we do this ultrasound. That is maybe 1 day, maybe 2 days later than the actual impact of the stroke. And we need to focus on the very early detection of those emboli, and their imaging, CT or MRI, for example, might be an option, because they can be done very early on within the first imaging of the stroke.
So your suggestion would also be to possibly even do this during the acute diagnosis of the patient?
That would be the gold way, so to say, because we have the patients in the CT scanner anyways to do the acute scan and see the vessels, perfusion imaging, whatever. We just have to scan a little bit lower to see whether there's thrombotic material in the LR. If we see that, this would change directly the treatment direction, because normally we could give antiplatelet therapy. If we know there's a thrombus within the heart, we will not give antiplatelet inhibition. We would go for antithrombotic, or like heparin or DOAC, for example.
Thank you very much. Dr. Holtmannspetter, for you as an interventionalist, actually the past years, I would say, have really changed everything. So mechanical thrombectomy, the first trials came out back in 2015, and since then large vessel occlusion has the gold standard for treatment of large vessel occlusion pretty much has been changed to mechanical thrombectomy. For you as an interventionalist who is using imaging equipment on a daily basis, what kind of new challenges have occurred and what is actually really needed so that you can do this very, very time-sensitive procedure with patients whose lives are at stake right now? What can imaging do so that this treatment can be done in the best way possible?
Yeah, thank you. That's a complex question. Yeah, of course, over the last 20 years, actually, I'm doing thrombectomy, and since 10 years, almost 10 years, with the backup of evidence, that's the right way to treat large vessel occlusions. The techniques for thrombectomy have been improved to a large extent, so like roughly 9 out of 10 occlusions we can open up. So the main challenge is to do the right patient selection and to be as fast as possible. So already the IMS-3 study has shown that like 10, 20, 30 minutes delay in reopening vessel reduces the chance by 10%. They're corrected for any factors. So the difficulty is in an interdisciplinary setting to set up the right logistics. So how many steps have we to do, and how to get the patient as fast as possible to the angio suite. So the technique is in place. We have good quality imaging. So can we bypass, for example, one step? So the recent development I'm pretty excited about is bypassing CT in the setting where the patient has suspicion of a large vessel occlusion, severely clinical impact, and is sent directly to angio suite, and there proper imaging can be done. That is exclusion of hematoma, of intracerebral hemorrhage, and the proof that there's a vessel occluded. So additionally, possibly there can be some multi-phase perfusion-like imaging, I think, which is an extra important tool in the new development, mostly to detect the more distal occlusions. And I think, so if we can streamline the patient flow towards the fast diagnostic and immediate proceeding towards thrombectomy, that would be the biggest gain in time which we can achieve.
Thank you very much. At the moment, you just mentioned perfusion imaging, so this could help for patient selection, but also for detection of more distal occlusions. Could there also be a scenario? So what I'm thinking of right now is endpoint determination. On the one hand, you want to get as much thrombus material out of the brain as possible with the least pass as possible. But then, of course, whenever there's a second or third or fourth pass, then you also increase the complication risk. Could you imagine that there is a case where you also would find a patient who doesn't look perfect on angiography, but on perfusion actually is fine already, which could also help you stop the procedure at that point?
Well, it's pretty difficult to say with the data available now. So there are ongoing trials. So the one trial, tension trial, and other trials have shown that even with a large infarction, there's a benefit in the patient. The other trials are going on with already successful thrombectomy, and angiography looks nice. That additional 10 ectoplase or alteplase IV improves further the outcome. So there are minor changes there, and not just the macroscopic angiographic image is decisive and the time, but also on the level of microperfusion, and I'm sure Jan Lehmann can answer these questions much better on that level. I think there's a lot of chances to for further improvement of patient treatment. But it's maybe, that has to be shown then, perfusion can give some answers in selecting the right patients for escalation of thrombectomy for further IA or IV thrombolysis.
Thank you very much. Professor Lehmann, we just talked about large vessel occlusion, but of course there's many more strokes, and it doesn't always end in large vessel occlusion and thrombectomy. But in general, when you have an acute stroke patient, and we just heard one possibility to shorten the time to treatment would be inside the hospital. But when a patient actually is suffering from a stroke, could you describe a little bit the challenges and also the situations the patients often find themselves in when the symptoms set on until they actually reach the hospital and the treatment is initiated? And also, what kind of ways would be available to also shorten time to treatment in this case? So is there anything which we can support so that, for example, treatment can start even outside the hospital? So what kind of challenges are paramedics, doctors, patients faced with outside the hospital, and how can we really help also as a medical technology provider to really shorten the time until the treatment finally starts?
Yeah, thank you for this question. One challenge is time to hospital, time to right hospital would be the correct answer, I think. For time to right hospital, you need time to diagnosis or the right diagnosis. So what we need is, that is something the paramedics need. They need scores or something at hand where they can prove their diagnosis or reassure their early diagnosis they have. So communication is one big factor. So a possibility for the paramedics to communicate with doctors in hospital, with specialists, for example, would be one way. The time to diagnosis and time to right diagnosis could be improved very early on. And then you can choose the direction the patient goes. Is it really a stroke? Is it something else? And that limits you to a few hospitals where the patient can actually be treated the best way. You don't always need the thrombectomy center, because if you see, okay, this is probably a stroke, but the symptoms the patient is presenting, they're not really typical for large vessel occlusion, and that experienced neurologists in a lot of cases can already say by just examining the patient, and their telemedicine would be one way to go for. Then you can leave the patient in the next neurological department where thrombolysis and the imaging and the whole other stuff can be done. On the other hand, if you see that it's a patient, cortical signs, whatever, who most probably has either a large bleeding, needing at some point of time neurosurgery, or needs an LVO reopening by the neurointerventionalist, then the direct way to the right hospital, so to the thrombectomy center, would be possible early on, and bypassing possibly, I know that's a difficult question politically also, the small stroke center and directly entering the big stroke center. So communication is one big field where we definitely need new devices, new technologies and software where we can easily communicate with the paramedics. With the smaller hospitals, if they have questions, there's already some approaches within the networks, the stroke networks. We also have in Nuremberg. But this can be largely improved, yes.
Okay, thank you very much. We also just heard that imaging is of essence. You need to exclude a hemorrhage in the brain. One way of addressing this is the so-called mobile stroke unit. What is your take on this?
That is
possibility?
That is one approach which is definitely worth to go further for. In my opinion, it's not fitting to every geographically or geographic surrounding. So in some cities, Berlin, for example, this might be an option. I think in more rural areas where you have large areas you have to drive to, this might be a bit difficult, because if the stroke mobile is out to the one end of this area and the next stroke is occurring in the other end, you would need a lot of stroke mobiles to actually cover all these regions. Whereas in Berlin, for example, the regions are smaller and you end up with 2-3 STEMO mobiles, which they have already. But their telemedicine with online systems, for example, on a normal mobile would be, I think, the easiest way, and not necessarily that you have a CT scanner on the car.
Understood. So communication is more crucial than having the imaging right away. This largely depends on also the geographical setting. And but it would be a huge help if, for example, you as a neurologist in the hospital would be able to communicate with the paramedics on site and with the patient, maybe even so that you could even do a diagnosis at least remotely.
I think both ways are feasible, but it depends on where you actually want to apply them.
Mm-hmm. Very good, thank you. Dr. Holtmannspetter, we just heard about brain hemorrhage. I mean, this is also a type it's a bleeding which oftentimes causes a stroke, but usually comes from completely different backgrounds. One of which is, for example, aneurysms which rupture. There, I would be really interested. I mean, an aneurysm is a completely different disease than ischemic stroke. What kind of challenges do you have in identifying the patients which need treatment? I mean, there is certain ways of treatment, and some of the patients will maybe just be getting medical treatment, but then there's also patients which are eligible for interventional treatment. So how do you decide on which patients need which treatment? And is there anything which you could wish for, which you could hope for, which would actually make this decision between should I treat a patient or not, and maybe also what keeps you from treating a patient, where we could help as an imaging provider?
Well, the main thing is risk stratification. Yeah. So unfortunately, there's a risk in treating aneurysms. Yeah, we've become much better. Yeah, 10 years, 15 years ago, I consented patients for a risk for neurological complications from like 6 to 8%. Now it's down to 2.4, 2 to 4% in average. But that's the problem. And then how to stratify rupture risk for an incidental finding. That's still our main difficulty. There are scores around, FACES score, there's a ESOC study, but none of those scores and those studies really mirror the reality perfectly. They're just adjuncts to find the way. So the size of the aneurysm, the location of the aneurysm, and then some additional factors like some very rare genetic ones, which usually play only a co-role, but main risk factors, hypertonia, arterial hypertonia, and smoking. So these are the most important factors for aneurysm rupture. So what do you tell a patient who is 30 years with a small aneurysm where you don't actually know the risk of rupture, and what do you tell a 90-year-old patient with the same aneurysm? This is a no-brainer, because if you have a 2 to 4% risk to damage somebody, so you need to have a risk assessment. I think from the imaging side, coming back to a question finally, the biggest challenge is to kind of see a vulnerability inside the aneurysm, not just some eyeballing factors. And vessel wall imaging has become a widespread used tool. Many physicians use that to get a better idea on it. So if you have the intention rather not to treat because you think the risk for rupture is not very high, you try to support that decision with vessel wall imaging and say, okay, there's no contrast enhancement. We know from studies that the ruptured aneurysms have inflammatory response in the ruptured vessel wall. So this is an extra information, but it's not proven. We don't have the data yet. But it's a good educated guess, which helps us to make this decision. I think there are further possibilities regarding this imaging. I think just recently OCT has become available in some areas of the world for intravascular vessel wall imaging with a very high resolution. And then we can correlate what we see in vessel wall imaging. Is it really weakness of the aneurysm wall or not? And then with these informations, we can then deal for maybe medical treatment, just give aspirin, which helps in many situations, obviously, not only in aneurysm, and or follow up or go for treatment. Yeah? So possibly the decision for treatment becomes easier if our technique and safety protocols evolve further on, hopefully. Yeah.
Okay. One more question I would have about the actual treatment. There is also certain tools available for that. So on the one hand, of course, we try to provide as much insight into the actual patient's anatomy by providing, for example, 3D roadmap imaging, which can give you an impression of the shape and the size and location of the aneurysm. But there's other tools which also allow to really play through, simulate an implantation of a device. Is there any value in those tools as well?
Definitely. I think this is, when endovascular treatment of aneurysm became available, we used these platinum coils in all aneurysm. But thanks to industry support and engineering efforts, we have now not only coils, but we have a widespread portfolio of options, so we can do tailored treatment of the aneurysm. The downside to it that we have a lack of experience for the individual method, because there are not more aneurysms or more ruptures which need to be treated. So simulation to help us before we enter the aneurysm or start treating the aneurysm to decide which of those options is the right one helps us to bypass this lack of experience with the single device. It's not about getting there, it's how to treat, how to understand how each different device behaves in anatomic surroundings. And I think we can't go, it's not helpful. I think in future we can't get around it. We will need that, yeah?
Okay, thank you very much. Professor Liemann, you earlier said that a large part of strokes is actually originating from the heart. And you mentioned already a little bit that ultrasound is being used as a standard imaging for that. What is generally done to really confirm that a stroke in fact has originated from the heart? What are the limitations of what you're using right now? You mentioned ultrasound, and you said that maybe CT or MR could help in that case. And what could be done to really overcome these limitations?
So what we do at the moment is ultrasound, either from outside, so TTE or TEE, so transesophageal. We see then thrombotic material maybe, and then we assume, okay, if there's no other underlying source which we found, for example, stenosis, extracranial or intracranial, that this most probably is the reason for the occurred stroke. So it's an exclusion process. So we do this imaging. We hope that we find some sources for the stroke, and then we treat the most dangerous source that we see. So if there's a thrombus within the heart, for example, or we see atrial fibrillation within Holter monitoring, for example, and there's no other concurring reason for the stroke, then we treat that reason. It's getting difficult when the patient has more reasons to get the stroke. So ipsilateral stenosis, for example, plus atrial fibrillation or thrombus or some other underlying disease. Then we have to decide, okay, which is the most probable reason for that stroke, and then we need imaging to actually see, okay, is maybe the stenosis the causing underlying source for the thrombotic material which entered the stroke. So MRI imaging, for example, plug imaging maybe, to see is this a vulnerable plug which is causing microemboli all the time, for example, or within the plug is there some instability, or heart imaging to see, okay, is there a high risk of getting atrial fibrillation or having atrial fibrillation, and how is the localization of the stroke. Is it only unilateral or is it bilateral, for example? So imaging is very important for us. And what helps us really is better imaging for plaque, for atherosclerotic plaques within the carotid artery, for example, and also heart imaging, which is easier to do and more early on within the treatment course.
Easier and more earlier than now.
Okay. Exactly. Yeah.
So I was actually also very interested because I recently read about cardiac MRI and actually a plethora of different things you can look for. So, for example, the heart wall, which you can look into, then also the coronaries, which you can look into, and then, of course, thrombotic material. But then also what I often heard was it takes very long.
Yeah.
What would be a tolerable time for you? Let's say that too long is not too long.
Yeah, it really depends on when you want to do this diagnostic. So early on, when the patient is entering the hospital, they are most of the time very unstable and move a lot. So there, I think a CT scan within a minute or something is the maximum, or 2 minutes they tolerate. Later on, 20 to 30 minutes is something I think which a patient can easily tolerate. But the longer it takes, the less good the quality of the imaging actually gets. We see that in the MRI images. If we get a prolonged protocol, because we have some special questions, vessel wall imaging, for example, something the patient has to stay there 40 minutes. And a lot of times the patients get very, movable in the end, and so the pictures get blurred, and we don't get the detailed information we actually would get if the patient would stay there very still, and the whole thing would only take 10 minutes or 20 minutes. So 20 minutes, maximum 30 minutes, I think.
Thank you. Dr. Heldmanspetter, actually we have time for one last question. We just heard also about plug imaging in the carotids. So at the moment there is different ways of doing that. Would you please just briefly go into the limitations of the current imaging of specifically plug? And also there is, for example, photon counting CT, which was recently released. Is there anything you could expect or hope for that this new technology could help you with?
I'm sure that we will find good use for the new technology. So but we need to find out what are the criteria which make us finally do a treatment decision. So like Professor Lehmann just pointed out, that the clinical impact is crucial. So can you decide which side? If it's just an incidental finding, it becomes very difficult. So if one carotid wall is sick, most likely the other carotid wall is also sick, and then you need to think, okay, also the way up there, there are many sources which could provoke a stroke. If you have a symptom which gives you direction, okay, look there, then I think it's very helpful when we can make a decision. This is a vulnerable plaque by MR or by the new CT technique, to make this decision, to make a differentiation between it could be just a plaque, which is asymptomatic with a so-called cryptogenic stroke, and then we go for treatment and we treat the lesion and we feel safe, but the patient is not on the safe side yet because his stroke origin or risk comes somewhere else from. So I think that further helps to make us the right decisions. If we can do like vessel wall imaging by MRI or by proton counting CT. I'm very much looking forward to that.
Okay. I think we're right on time. Thank you a lot for this great discussion, for the great insights you were able to provide us with. For me, it was a great pleasure to have this interview with you. And that all being said, I wish you a successful conference and hope to see you again soon.
Thank you very much for having us here.